السلام عليكم.
عليكم السلام ورحمة الله.
Good afternoon, everyone. So, welcome to our cardiac surgery academic activity. So today we'll start our new section about coronary artery disease. We'll start today with 3 lectures. The first one is pathophysiology of coronary artery disease, will be presented by Dr. Abdullah Al-Ataibi. Myocardial infarction by Dr. Faisal Al-Ghamdi, and syntax trial by Dr. Abdul Hadi Al-Alma. We're glad to have Dr. Walid Al-Ayadi, who's a consultant at King Saud University Medical City, to moderate this session. So I believe we can start 5 minutes past 1. Dr. Abdullah.
السلام عليكم.
السلام ورحمة الله. تفضل.
الصوت واضح؟
نعم.
Good afternoon, everybody. My name is Abdullah Ataibi. I'm R2 cardiac surgery resident at KFMC. Today, inshallah, I will talk about pathophysiology of coronary artery disease. So my objectives, I will just speak a little bit brief about introduction about coronary artery disease, risk factor, pathogenesis of atherosclerosis, role of acute plaque changes, progression of ischemic myocardial injury, and tissue repair following myocardial infarction. Coronary artery disease, the major cause of death and disability in developed countries. Although coronary artery disease mortality rates worldwide have declined over the past 4 decades, but it's remained responsible for about 1/3 or more in all deaths of individualized over age 35. It has been estimated that nearly 1/2 of all middle-aged men and 1/3 of middle-aged women in the United States will develop some manifestation of coronary artery disease. Myocardial ischemia occur when perfusion via coronary flow is inadequate to meet metabolic needs, thus interfering with both the cellular delivery of oxygen and nutrients to cardiac myocyte and removal of waste products. Myocardial ischemia most often result from obstruction or narrowing of coronary artery secondary to atherosclerosis. So coming to the definition of atherosclerosis, it's a chronic progressive inflammation and fibrotic disease of arterial wall of large and medium vessel aggravated by risk factors. Atherosclerosis is a multifocal disease of vessel wall beginning in the intima, whose characteristic lesion is the atheroma or plaque that forms through intimal thickening, mediated predominantly by smooth muscle cells proliferation and matrix production and lipid accumulation. There are some non-atherosclerotic epicardial coronary artery obstruction, which can occur in autoimmune disease like SLE, rheumatoid arthritis, progressive systemic sclerosis, vasculitis, like Kawasaki disease, and as a result of dissection, spasm, embolism, or some drugs like cocaine. Decreased coronary flow leading to global hypoperfusion and myocardial ischemia can occur during cardiopulmonary bypass. Also, ischemia can occur result from increased cardiac demand secondary to exercise, tachycardia, hyperthyroidism, or ventricular hypertrophy or dilation. Moreover, the effects of ischemia are potentiated when oxygen supply is decreased secondary to anemia, hypoxia, or cardiac failure. Risk factors, we have non-modifiable risk factors like increasing in age, male sex, family history, ethnic region. Modifiable risk factors, smoking, hypertension, dyslipidemia, diabetes, obesity, psychological stress, high calorie, high fat diet, and physical inactivity. Smoking cessation carries almost immediate benefit, and although long-term benefits are greatest in those who stop smoking before age 40, stopping in middle age also beneficial. Now coming to brief histological structure of blood vessel, we have the most inner layer, which is the intima, mainly endothelial, and the inner layer, which media, tunica, which mainly formed by smooth muscle cells and elastic fibers, and the most superficial layers, adventitia, which mainly formed by collagen fibers. And the atherogenic process characterized by dysfunction of endothelial lining of the vessel, inflammation of vascular wall, buildup of lipids, cholesterol, and inflammatory cells in the vessel wall, accumulation of cellular debris within the intima and subintimal layers of the vessels. Now, first step, we have endothelial dysfunction. It causes vasoconstriction due to decreased production of nitric oxide, increased permeability to lipoproteins, expression of tissue factor leading to thrombosis, expression of certain injury, induce adhesion molecules leading to adherence of platelets and inflammatory cells. These features lead to two phases of atherosclerosis. Usually the first stage is named as linear fatty streak, which is focal intimal thickening caused by this deposition of lipid-filled macrophages and smooth muscle cells. The second stage is fibrolipid plaques, consisting of these lipid-laden cells and inflammatory core and cholesterol deposits encased by fibrous cap, resulting in laminar narrowing. This picture summarizes the pathogenesis of atherosclerosis. It starts with endothelial dysfunction and lipoprotein deposition, as well as monocyte adherence to subendothelial layers, and then transformation of monocyte to macrophages and lipid being phagocytosed by macrophages forming foam cells, then leading to smooth muscle migration from the medial layer into the subendothelial layer and proliferation and formation of extracellular matrix, leading to collagen formation. This leads to formation of fibrous cap. Once there is rupture of the fibrous cap, leading to thrombus formation. Again, this is stages of atherosclerosis. Initially fatty streaks, mainly intracellular lipid accumulation, intermediate lesion, intracellular lipid accumulation, as well as extracellular lipids and proteolysis, atheroma, intracellular lipid accumulation, large extracellular lipid mass and inflammation. Also fibroatheroma, large lipid core, fibrosis, calcification of plaque and of plaque inflammation. Complicated lesion, endothelial lesion, hematoma, and thrombus formation and inflammation. Blood flow through the arteries causes local generation of fluid, shear stress, with which influence the biology of underlying endothelial cells. High laminar shear from blood flowing quickly through the straight vessel favor the generation of nitric oxide, which help maintaining the functional integrity of the vessel. In contrast, low shear caused by turbulent flow causes dysfunction to underlying endothelial cells, which facilitates initiation and the progression of atheroma. This helps explain why plaques are found more commonly at site of vessel branching or curvature, which experience more dramatic and abrupt changes and irregularities of direction and velocity of blood flow. Clinical manifestation of advanced coronary arterial atherosclerosis occur through encroachment of the lumen, leading to progressive stenosis or acute plaque disruption with thrombosis. In the absence of coronary blockage, myocardial perfusion is adequate at rest, and compensatory vasodilation provides flow reserve that's more than sufficient to accommodate increased metabolic demand during vigorous exertion. When the coronary laminar cross-sectional areas decrease approximately 75%, blood flow becomes limited during exertion. With a 90% reduction, coronary flow may be inadequate at rest. However, occlusions that develop slowly may stimulate the formation of collateral vessels that protect against distal myocardial ischemia. Aneurysms may form secondary to atherosclerosis as a result of destruction of the media beneath the plaque process, most common in the aorta and other large vessels, where the plaque does not easily cause obstruction. Role of acute plaque changes. The conversion of stable angina or an asymptomatic state to acute coronary syndrome is dependent on dynamic vascular changes, such as a fracture or rupture of the fibrous cap, exposing deep plaque constitute and subsequent thrombus, whether occlusive or partial, sometime with emboli. Less commonly, the change is erosion or ulceration of the fibrous cap, setting the stage for platelet aggregation and mural or total thrombosis. This diagram shows the preclinical phase, which is asymptomatic, usually initiated by the fatty streak, the initial stage, by endothelial dysfunction, monocyte migration, smooth muscle cell migration to intimate proliferation with extracellular matrix and lipid accumulation. Once the plaque progress and growth more forming fibrofatty plaque causes more cell death, degeneration, plaque growth, remodeling of plaque and extracellular matrix wall, organization of thrombus, and calcification. This leads to advanced level of vulnerable plaque, leading to either three phases: aneurysm and rupture, which rupture through the media layer, occlusion by thrombus when there is rupture of fibrous cup, or progressive growth leading to critical stenosis. Usually in the first stage, asymptomatic, may manifest to the stable angina, which is dyspnea upon exertion, but when the plaque advance, causing narrowing, more than 75% of laminar cross-sectional flow, diameter causing unstable angina, which is mild to moderate narrowing of artery, progressing more to moderate to severe, may cause non-STEMI, which is evidence of myocardial ischemia, but no complete occlusion. And if there is occlusion by a thrombus, total occlusion causing STEMI. Plaques having a high propensity to rupture are known as vulnerable plaques. Such lesions have a thin collagenous fibrous cap and few smooth muscle cells. The smooth muscle cells which produce collagen matrix. Contains many macrophages producing matrix metalloproteinase, which that enzyme that degrades the collagen that lends to strength of fibrous cap, and contain large area foam cells, which is mainly macrophages, phagocytosed lipid, extracellular lipid, and necrotic lipids. This is type of lesion where we have stable plaque, could lead to stenotic plaque, which is few fibrotic, thick cap, less compensatory, and enlargement, may manifest with ischemia. And we have vulnerable plaque, which may cause obstruction, non-stenotic, usually characterized by lipid-rich, thin cap, and compensatory enlargement. Inflammation may contribute to coronary thrombosis by altering the balance between prothrombotic and fibrinolytic properties of the endothelium. There is evidence that lipid lowering by diet or drugs such as HMG-CoA reductase inhibitors like statins reduce the accumulation of macrophages expressing matrix degrading enzyme, and thereby stabilize plaque by increasing the thickness and strength of the fibrous cap. Progression of ischemic myocardial injury. Once there is decreased coronary perfusion at cellular level, there is a transformation of, from aerobic glycolysis into anaerobic metabolism due to decrease of ATP. This transformation lead to increased level of lactate, accumulation of lactate in the cellular level, which causes cellular acidosis. This is within seconds. Loss of contractility less than 2 minutes. ATP reduces to 50 of normal within 10 minutes. Irreversible cell injury usually happens between 20 to 40 minutes, depending on the severity of ischemia. Microvascular injury more than 1 hour. Pathological feature, ultrastructural feature, reversible injury 5 to 10 minutes, with irreversible damage 20 to 40 minutes. Classic histological feature of necrosis occurs within 6 to 12 hours. Gross alterations 12 to 24 hours. Again, this figure, the left one, summarize when there is ischemia, there is significant drop of ATP level in the cells within seconds, and lead to transformation of anaerobic metabolism, leads to accumulation of lactate. And then the right figures, myocardial injury is potentially reversible for approximately 20 after the onset of severe ischemia, and progressive loss of viability occurs, which complete by 6 to 12 hours. The benefit of reperfusion are greatest when achieved early. Lastly, we talk about tissue repair following MI. The inflammatory reaction is characterized by early exudation of polymorphic nuclear leukocytes seen after 6 to 12 hours and maximum within 1 to 3 days. Subsequently, 3 to 5 days, the infiltrate of consists predominantly of macrophages that remove the necrotic tissue. Collagen production accompanied by new vascularization begin approximately 7 to 10 days at the margin of preserved tissue. Ultimately, the infarct tissue is replaced by dense collagenous scar, which fully mature about 6 to 8 weeks. That was my end of presentation. Any question?
Abdullah,
Yes, I have.
thank you for your presentation. Just to get back to you have talked about aneurysm formation. I didn't get that related to the MI itself.
I just mentioned aneurysm formation as a part of atherosclerosis. It's more common in the large vessels, not in medium vessels, because in large vessels the chances of plaque blocking the lumen is less comparing to the medium. That's why the aneurysm might invade to the medial layer, causing rupture.
Okay, what about the bifurcation? Forming a plaque on the, forming a plaque on the bifurcation of the fizzles.
Yes, there is increased risk and bifurcation curvature of the blood vessel to form a plaque because due to the narrowing and high stress shear velocity of blood flow.
Oh yeah, I thought something else. خلاص, okay, clear. Thank you.
Anyone has any question or comment for Abdullah? Okay, thank you, Abdullah. So we are ahead of time, so let's just see when Dr. Walid will be able to join us for the second lecture. So while waiting, I have a couple of announcements and requests. We are really encouraged by the Saudi Council to have a consultant who participate with us in this activity. And it is the presenter responsibility, as we said in the beginning of the activity, but we are here to help at any time. But what I'm asking that the presenter should inform us ahead of time so we can arrange with another consultant from our side if he cannot do that from his side. So at least maybe 1 or 2 weeks so we can arrange with consultants. You can, if you are a junior resident, you can call the chief resident or the seniors with you to help. But if you could not arrange, you can call me or chief resident Faisal to arrange from our side and to help. It would really enrich our sessions, and it is really encouraged by the Saudi Council. The second thing is the minimum time for the lecture is at least 1 hour, so that the presenter is responsible to fill this time. So if he finish his presentation early, he could like do a scenario or MCQs, so he covered the subject thoroughly. So it's your responsibility as a presenter to have at least 1 hour to finish your presentation, and then like 10 to 15 minutes for discussion. The third thing that also the Saudi Council is requesting to have a full half-day activity. That's mean from 1 o'clock to 5 o'clock. So we may adjust the schedule and add more lectures in the coming days, maybe by adding more journal club sessions. So you might be asked to present an extra session. So we will arrange for that and we'll let you know ahead of time, inshallah. If anyone has any comment or question to discuss regarding this announcement, please welcome. Okay, so we'll have a 5 minutes break and then we'll start our session.
Sure, thank you, Lai.
Okay, I believe we can start now. I would like first to welcome Dr. Walid Al-Ayadi, who is a consultant cardiac surgeon at King Saud University Medical City. Welcome, Dr. Walid, to our session.
أهلا وسهلا, الله يسلمك.
Dr. Faisal, you can start.
Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Is my voice clear or is there any issue?
Clear.
Okay, great. So today my topic will be about revascularization guidelines. I will be going through the American Heart Association and the European Society of Cardiology guidelines regarding revascularization in patients with coronary artery disease. And I will be focusing mainly on CABG. So the outline of my lecture will be, we will first talk about some important definitions and the approach to revascularization decision, and this, revascularization in patients with stable coronary artery disease, and also in patients with non-ST elevation acute coronary syndrome, and also patients with ST elevation MI, and extra clinical subsets. The guidelines I will be covering, or I included in my review, are the American Heart Association guidelines, the CABG guidelines. The latest was in 2011, and the guidelines for the stable ischemic heart disease, for the non-ST elevation acute coronary syndrome, and for the ST elevation MI. Also the European Society of Cardiology, which is the latest. So first, what are the goals of revascularization? Can anyone answer? Why do we revascularize patients with coronary artery disease?
To help them restoring the flow to the not infarcted, not scarred, but a viable tissue before getting infarcted.
Okay, so what you are saying, Ayat, is we do revascularization procedures to restore flow to the coronary arteries.
Yeah.
Okay, any other answer? Okay, so we revascularize patients, not as you said, Ayat, just to restore flow to the coronary arteries. Our two main goals are two: either to improve survival or to relieve the symptoms. If our procedure will not achieve any of these two, it's just putting the patient at the risk of complication for nothing. So with that in mind, I will just mention some definitions before we go through the guidelines. Through these guidelines, they mention significant coronary artery stenosis. There are two definitions for significant coronary artery stenosis. There is the anatomic definition and the physiologic definition. Anatomic definition, both guidelines, both societies, the American and the European, agreed that the significant left main stenosis has to be a narrowing of 50% or more. While the other coronary arteries, I noticed that in the American, they name the stenosis as a significant when it's 70% or more. While in the European guidelines, it has to be at least 50%. So the European has a lower threshold. For the physiologic, set the FFR as has to be 0.8 or less for the lesion to be significant. Before we move, does anyone know what FFR means? Hello? Do you hear me?
Yes, we can hear you.
So FFR, what does FFR mean?
Fractional flow reserve.
Okay, thank you, Dr. Luay. Another thing that I need to also mention is the syntax score. Syntax score is a score that is used to assess the extent of the coronary artery disease, to quantify the complexity of the anatomy. And a low score, which equates to low complex disease, is 22 or less. High is a 33 or more. Before we move to the indications for revascularization, we need to mention the guidelines. So on the 11, it was an approach to revascularize for revascularization, especially in patients with unprotected left main or complex coronary artery disease. It was also class 2A to use the STS score and the syntax score in patients with unprotected left main and complex coronary artery disease. The syntax score has two main uses. As we mentioned before, it is used to quantify the complexity of the disease. Also, it is used to predict the risk for mortality and morbidity in patients undergoing PCI. So if someone is going to undergo CABG and we want to predict the risk for mortality and morbidity, we will use the STS. But if someone is going to undergo the PCI, we use the syntax score to predict the risk of their morbidity and mortality. For the European Society of Cardiology, their guidelines are almost the same. To assess the surgical risk for patients who are candidate for CABG, it's class 1 to use the STS score to assess the in-hospital 30-day mortality and in-hospital morbidity after CABG. While the Euroscore had an indication of class 2B. This shows you that the STS score is superior to the Euroscore for the prediction of mortality and morbidity in patients undergoing CABG. Also, for the assessment of coronary artery disease complexity, in patients with left main or multi-vessel disease, it is recommended to use the syntax score, and this was a class 1 indication. Class 2A was, when considering the decision between CABG and PCI, completeness of revascularization should be prioritized. Also, in the European, for the decision-making and patient information in the elective settings, these are also extra important information. These are all class 1 indication. It is recommended that patients undergoing coronary angiography are informed about the benefits and risks, as well as potential therapeutic consequences. It is also recommended that patients are adequately informed about short and long-term benefits and risks of revascularization procedure, with information about local experience and allowed enough time for informed decision-making. This is, we are speaking now about elective setting, not an emergency setting. It is recommended that institutional protocols are developed by the heart team to implement the appropriate revascularization strategy in accordance with the current guidelines. In PCI centers without on-site surgery, it is recommended that the institutional protocols are established with partner institutions providing cardiac surgery. So now we will move to the indication and guidelines for revascularization in patients with stable coronary artery disease. So for the goal of improvement of survival, in the European Society of Cardiology, they went through another approach of going through the guidelines. They first listed the anatomy that matches the indication for revascularization to improve survival. For the anatomy that is where the revascularization is indicated for survival, first left main disease stenosis with more than 50%, proximal LAD more than 50%, 2 or 3 vessel disease with stenosis of 50% with impaired LV function, ejection fraction less than 35, large area of ischemia detected by functional testing, 10% or more LV or abnormal invasive FFR, single remaining patent coronary artery with a stenosis of more than 50%. In the American Heart Association guidelines, the CABG, the left main coronary artery disease, in the setting of left main coronary artery disease, CABG is always class 1 indication. In respect of PCI, it is never class 1 with the left main coronary artery disease. There are certain settings where PCI is indicated for, so when it's class 2A, for in the setting of a stable ischemic heart disease, when both or of the following are present: anatomic condition associated with low risk of PCI, procedural complications, and high likelihood of good long-term outcome. So they have to have a syntax score less than 22%, or a left main that is ostial or a disease in the trunk of the left main. The other condition is clinical characteristic that predict a significantly increased risk of adverse surgical outcome, like a patient with high STS score. An STS score of 5% or more could make us change the decision from CABG to PCI. And the setting, this is for unstable angina and non-STEMI. PCI for a patient with left main disease is class 2A if the patient is not CABG candidate. It's also class 2A in cases of STEMI when distal coronary flow is STEMI flow grade less than 3, and PCI can be performed more rapidly and safely than CABG. PCI is class 2B in the setting of stable ischemic heart disease when both of the following are present. Here, the difference between this 2B and 2A, which is the first one, is that here you can do PCI in patient left main when the score is intermediate, low or intermediate, but it's class 2B, and when the patient had an STS score more than 2%. PCI is considered harmful for the patient when he has a stable ischemic heart disease versus performing CABG with unfavorable anatomy for PCI and who are good candidates for CABG. While in the European Society of Cardiology, CABG is always class 1 for all patients with the left main, either low or intermediate or high syntax. But the PCI is considered class 1 in patients with low syntax score. It's considered class 2A in patients with intermediate, and 3, which is harmful for patients with high syntax score. And this makes sense when you remember what I said in the beginning, that syntax score can predict morbidity and mortality of patients undergoing PCI. So patients with high syntax score means they are at high risk of morbidity and mortality after PCI. For patients with 3-vessel disease, CABG is also class 1, according to the American Heart Association CABG guidelines. It's also class 2A to choose CABG over PCI in patients with complex coronary artery disease and intermediate and low and high syntax score who are good candidates for CABG. PCI is class 2B of uncertain benefit. In the European Society of Cardiology, they differ in the patient's population with low syntax score. PCI and CABG are equal in the patient with 3-vessel disease without diabetes mellitus. Patients with 3-vessel disease with high or intermediate syntax score, CABG is better for them, and PCI is harmful. Patients with diabetes mellitus, PCI takes lower recommendations in all syntax score. The highest PCI, the best PCI recommendation is 2B in patients with low syntax score. Patients with 2-vessel disease with proximal LAD, according to the American Heart Association guidelines for CABG, is class 1. CABG is class 1, while PCI is of uncertain benefit. Also, patients with 2-vessel but without proximal LAD, CABG for the improvement of survival is 2A, especially when the patient had extensive ischemia. It's considered 2B if the patient of uncertain benefit without extensive ischemia. 2B, PCI has uncertain benefit, but it's still class 2B. According to the European, patients 2-vessel coronary artery disease, PCI is always class 1. But for CABG, if the patient has proximal LAD stenosis, it's without proximal LAD stenosis, 2B. If he has a proximal LAD stenosis, it's equal to PCI, and it's class 1, which I'm talking about now, CABG. 1-vessel disease with proximal LAD, CABG is class 2A. If you are gonna do the CABG with Lima for long-term benefit, while PCI is of uncertain benefit. 1-vessel disease without proximal LAD is always harmful to the patient. That is when your goal is improvement of survival. 1-vessel disease in the guidelines of the European Society of Cardiology, if it is without proximal LAD, it's class 1 for PCI. If it's with proximal LAD, it's also class 1. But for CABG, it's only class 1 when the patient has proximal LAD stenosis. In patients with LV dysfunction and heart failure, CABG is class 2A in patients with ejection fraction of 35% to 50%. CABG is also class 2B in the ejection fraction less than 35 without significant left-main coronary artery disease. While in the European Society of Cardiology, the recommendation in patients with LV dysfunction heart failure for the goal of improvement of survival, in patients with severe LV systolic dysfunction and coronary artery disease suitable for intervention, myocardial revascularization is recommended. It's class 1 to revascularize a patient with LV dysfunction or heart failure that is of ischemic origin. CABG is also recommended as the first revascularization strategy choice in patients with multi-vessel disease and acceptable surgical risk. The same patient population and patients with 1 or 2 vessel disease, PCI should be considered as an alternative for CABG when complete revascularization can be achieved with CABG. That's class 2A. In patients with 3-vessel disease, PCI should be considered based on the evaluation by the heart team of the patient's coronary anatomy, the expected completeness of revascularization, diabetes status, and comorbidities. This is an entity that only the European guidelines mentioned. I did not read anything about it in the American guidelines. LV aneurysmectomy during CABG should be considered in patients with NYHA class 3 or 4, or patients with large aneurysm, large thrombus formation, or if the aneurysm is the origin of an arrhythmia. That's class 2A. Class 2B, surgical ventricular restoration during CABG may be considered in patients treated in centers with expertise. Just a couple of points I want to add before moving from this patient population. Coronary revascularization is superior in improving survival in patients with heart failure of ischemic origin when compared to medical therapy. PCI should be considered in older patients without diabetes in whom complete revascularization can be achieved. CABG is preferred in younger patients with more extensive coronary artery disease or those without diabetes. Regarding LV reconstruction and aneurysm resection, the aim of surgical ventricular reconstruction is to restore physiological volume and achieve an elliptical shape of the LV. While the aim of ventricular aneurysmectomy is to remove fibrous scar in cases of severe dilatation, thrombus formation, or as a source of life-threatening ventricular arrhythmia. Most of these guidelines come from the STITCH trial. The STITCH trial revealed no difference in the primary outcome, that is the total mortality or cardiac hospitalization, between patients randomly allocated to CABG versus combined CABG and SVR. When they did the subgroup analysis of patients with a less dilated LV and better LV ejection fraction, there was some benefit from SVR. Before we move on from the first goal of revascularization, I want to mention that most of these guidelines are established on 3 landmark RCTs. These RCTs establish the survival benefit of CABG compared with medical therapy without revascularization in certain subjects with stable angina. And these RCTs are the Veterans Affairs Cooperative Study, the European Coronary Surgery Study, and the CAS, which stands for Coronary Artery Surgery Study Registry and Trial. These, I just want to add, were performed in the 1970s and the 1980s, where medical therapy and techniques for CABG haven't advanced as much as now. If we were to repeat these trials now, maybe CABG would have more benefit, or medical therapy could replace CABG in certain populations. Now for the second goal of revascularization, which is to relieve symptoms. In the American Heart Association CABG guidelines of 2011, in patients with 1 or more significant coronary artery disease that is amenable to revascularization with unacceptable angina, despite guideline-directed medical therapy, both modalities of revascularization are class 1. Patients with 1 or more significant coronary artery disease and unacceptable angina in whom goal-directed medical therapy cannot be implemented, CABG and PCI are class 2A. In patients with previous CABG with 1 or more significant coronary artery disease that is associated with ischemia and unacceptable angina despite goal-directed medical therapy, PCI is class 2A and CABG is class 2B. CABG, I think, here went lower class of recommendation because of the high risk of undergoing a redo CABG. Patients with complex 3-vessel disease, meaning syntax score more than 22, with or without proximal LAD, and those patients who are good candidates for CABG, CABG is class 2A, and it's preferred over PCI. Viable ischemic myocardium that is perfused by coronary arteries that are not amenable to grafting, transmyocardial revascularization is class 2B as an adjunct to CABG. The last thing, when there is no anatomic or physiologic criteria for revascularization, CABG and PCI are considered harmful to the patients. For the European Society of Cardiology, as with the improved survival, they did not mention a lot of details. They just put the criteria for improvement of symptoms, but the indications for revascularization follow the improved survival anatomy, which we mentioned first. So for symptoms relief, hemodynamically significant coronary stenosis in the presence of limiting angina or angina equivalent with insufficient response to optimized medical therapy is class 1 for revascularization. This is from the European Society of Cardiology, summarizing patients who have coronary artery disease with characteristics that favors PCI or ones that favors CABG. And they divided them in different groups. There are clinical characteristics and anatomical and technical aspects. And the CABG, they added need for concomitant intervention. So in PCI, the patients who have characteristics that favors PCI, these clinical characteristics are either presence of severe or comorbidities, advanced age or frailty, reduced life expectancy, or restricted mobility and conditions that affect the rehabilitation process. For the anatomic and technical aspect, they should have a multi-vessel disease with syntax score that is low. Anatomy likely resulting in incomplete revascularization with CABG due to poor quality or missing conduit. Severe chest deformation or scoliosis, sequelae of chest radiation or porcellina aorta. Anatomies that favor, characteristics that favor CABG. The clinical ones are diabetes, LV dysfunction, contraindication to dual antiplatelet therapy, recurrent diffuse in-stent restenosis, and the anatomic and technical aspect, patients with intermediate or high syntax score, anatomy likely resulting in incomplete revascularization with PCI, severely calcified coronary artery lesions limiting lesion expansion, and the need for concomitant intervention, like someone with valvulopathy or ascending aorta surgery, ascending aortic pathology that requires surgery. Now for revascularization in patients, like specific indication in patients with non-ST acute coronary syndrome. Patients with non-ST acute coronary syndrome, the indications are similar with the stable coronary artery disease. The only difference is that in patients with in this patient population, the impetus for revascularization is stronger. The choice of revascularization method is generally dictated by the same consideration used to decide on PCI or CABG for patients with stable ischemic heart disease. In patients with non-ST elevation acute coronary syndrome, invasive evaluation guidelines in the European Society of Cardiology, urgent coronary angiography, which is less than 2 hours, is recommended in patients with very high ischemic risk. An early invasive strategy that is less than 24 hours is recommended in patients with at least one high-risk criterion. An invasive strategy that is less than 72 hours after first presentation, that is not that urgent, is indicated in patients with at least one intermediate risk criterion or recurrent symptoms. It is recommended to base the revascularization study, ad hoc culprit region PCI or multivessel PCI or CABG, on the clinical status and comorbidity as well as the disease severity. That is the distribution and angiographic lesion characteristics, the syntax score according to the principle for stable coronary artery disease. In patients with cardiogenic shock, routine revascularization of the non-infarction related artery lesion is not recommended during primary PCI. Regarding the high-risk features which were mentioned in the guidelines in the previous slides, this slide summarized them all, and you can go through them in the guideline text. Anyway, to summarize, the very high risk should undergo immediate invasive strategy within 2 hours, patients with high-risk features within 24 hours, and patients with intermediate risk within 72 hours. The timing of urgent CABG in patients with non-ST elevation acute coronary syndrome. In the American Heart Association of non-ST elevation ACS guidelines in 2014, it was class 1 that non-enteric coated aspirin should be administered preoperatively to patients undergoing CABG. In patients referred for elective CABG, Plavix and ticagrelor could be discontinued for at least 5 days before surgery, and prasugrel for at least 7 days before surgery. In patients referred for urgent CABG, Plavix and ticagrelor should be discontinued for at least 24 hours. In patients referred for CABG, short-acting intravenous glycoprotein 2B3A inhibitors, which are the eptifibatide and tirofiban, should be discontinued for at least 2 to 4 hours before surgery, while abciximab for at least 12 hours before to limit blood loss and transfusion. While class 2B was in patient referred for urgent CABG, it may be reasonable to perform surgery less than 5 days after clopidogrel or ticagrelor has been discontinued, and less than 7 days after prasugrel has been discontinued. Revascularization in patients with ST elevation MI. The primary PCI is the preferred reperfusion strategy. And primary PCI means a percutaneous is defined as the percutaneous catheter intervention in the setting of a ST elevation MI without previous fibrinolysis. Emergency CABG may be indicated in selected STEMI patients who are unsuitable for PCI. In the American Heart Association CABG guidelines in 2011 and the Stemi guidelines in 2013, it was class 1 that emergency CABG is recommended in patients with acute MI with these characteristics: primary PCI that has failed or cannot be performed, coronary anatomy that is unsuitable for CABG, and persistent ischemia of significant area of myocardium at rest and/or hemodynamic instability, refractory to non-surgical therapy is present. It is also class 1 that emergency CABG is recommended in patients undergoing surgical repair of a post-infarction mechanical complication of myocardial infarction. Also, emergency CABG is recommended in patients with cardiogenic shock and who are suitable for CABG irrespective of the time interval from MI to onset of shock and time from MI to CABG. Class 2A, patient with STEMI, CABG is reasonable as a revascularization strategy in patients with multivessel coronary artery disease with recurrent angina, or MI, within the first 48 hours of STEMI presentation as an alternative to more delayed strategy. Early revascularization with PCI or CABG is reasonable for selected patients who are more than 75 years of age with STEMI or left bundle branch block, who are suitable for revascularization irrespective of the time interval from MI to onset of shock. The use of mechanical circulatory support is reasonable in patients with STEMI who are hemodynamically unstable and require urgent CABG. It was class 2B that emergency CABG within 6 hours of symptoms onset may be considered in patients with STEMI who do not have cardiogenic shock and are not candidate for PCI or fibrinolytic therapy. Last thing, which is class 3, which is considered harmful to the patient, emergency CABG should not be performed in patients with persistent angina and a small area of viable myocardium who are stable hemodynamically. Emergency CABG should not be performed in patients with no reflow. That means successful epicardial reperfusion with unsuccessful microvascular reperfusion. For the European Society of Cardiology, they mentioned that CABG should not be considered in patients with ongoing ischemia, and large areas of jeopardized myocardium if PCI of the infarction-related artery cannot be performed, and that was class 2A. Regarding the timing of urgent CABG in patients with STEMI, in the American Heart Association STEMI guidelines, aspirin should not be withheld for patients who are going for urgent CABG. Clopidogrel and ticagrelor should be discontinued at least 24 hours before urgent on-pump CABG, if possible. Short-acting intravenous glycoprotein 2B3A receptor antagonist should be discontinued at least 2 to 4 hours before urgent CABG. And abciximab should be discontinued at least 12 hours before urgent CABG. It was class 2B that urgent off-pump CABG within 24 hours of clopidogrel or ticagrelor administration might be considered, especially if the benefit of prompt revascularization outweigh the risk of bleeding. Urgent CABG within 5 days of clopidogrel or ticagrelor administration or within 7 days of prasugrel administration might be considered, especially if the benefit of prompt revascularization outweigh the risk of bleeding. Now we will go with other clinical subsets. Excuse me just for 1 minute. Okay, sorry. So for other clinical subsets, patients who are in shock or acute heart failure, there was no mention in the guidelines that I reviewed about them, only in the American guidelines, while in the European, these were the guidelines. Emergency coronary angiography is indicated in patients with acute heart failure or cardiogenic shock complicating acute coronary syndrome. This was class 1. Emergency PCI of the culprit region is indicated for patients with cardiogenic shock due to STEMI or non-ST elevation acute coronary syndrome, independent of time delay or symptoms onset, if coronary anatomy is amenable to PCI. Emergency CABG is recommended for patients with cardiogenic shock if the coronary anatomy is not amenable to PCI, and that was class 1. In cases of hemodynamic instability, emergency surgical or catheter-based repair of mechanical complication of ACS is indicated as decided by the heart team. It was also class 2B that in selected patients with ACS and cardiogenic shock, that short-term mechanical circulatory support may be considered. Depending on patient's age, comorbidity, neurological function, and the prospect for long-term survival and predicted quality of life. Last thing, the routine use of intra-aortic balloon pump is considered harmful in patients with cardiogenic shock, which is caused by acute coronary syndrome. Most of these guidelines come from, or some of them come from a very notable trial. This trial, it was demonstrated that in patients with cardiogenic shock, that is complicated acute myocardial infarction, emergency revascularization with PCI or CABG improved long-term survival when compared with initial intensive medical therapy. So CABG and PCI increased survival with the same rate in patients with cardiogenic shock. But a sub-analysis of that trial compared patients who were treated with CABG or PCI, as I said, showed that survival rate between the two subgroups. And CABG should be considered in patients with cardiogenic shock who have suitable anatomy, particularly if successful PCI is not feasible. But if PCI is feasible, it is equal to CABG, as was also was mentioned in the European Society of Cardiology, the mechanical circulatory support in patients with shock that is complicating MI. It may be considered in refractory cardiogenic shock depending on the patient's variable clinical characteristics. In the aortic balloon pump, intra-aortic balloon pump, intra-aortic balloon pump increases the cardiac output and coronary and cerebral perfusion, while it decreases the ventricular workload. In a trial which was named the intra-aortic balloon pump Shock 2 trial, it showed that the use of intra-aortic balloon pump did not reduce the 30-day mortality and that there was no evidence of long-term benefit. And that's why it got a class 3 in the European Society of Cardiology. Also, another mode of mechanical support is the Ecmo. And the Ecmo, it was found in a meta-analysis of observational study that patients with cardiogenic shock, post-acute coronary syndrome, VA Ecmo increased the 30-day survival by 33% in comparison in patients with intra-aortic balloon pump. Another form is the Percutaneous Elbad. There are two types. There is the transaortic microaxial pump, or what is called the Impella, and there is the transseptal centrifugal assist device, which is the tandem heart. For these two devices, the evidence till now is still inconclusive. That's why it's not mentioned in the European guidelines. And the last form is the surgical LVAD. And I read that the outcome in patients with surgical LVAD is with acute coronary syndrome that is complicated by shock is comparable to patients who are on surgical LVAD for other indications. Another patient group that was also mentioned in the guidelines is the diabetic patients. For the American Heart Guidelines for Stable Ischemic Heart Disease in 2014, it was class 1 that a heart team approach to revascularization is used in patients with diabetes mellitus and complex multivessel coronary artery disease. Also, cabbage is generally recommended in preference to PCI to improve survival in patients with diabetes mellitus and multivessel coronary artery disease, for which revascularization is likely to improve survival. Like if they have the indication for improved survival with revascularization, like 3 vessels coronary artery disease or complex 2-vessel coronary artery disease involving the proximal LAD, especially if the Lima graft can be anastomosed to the LAD, provided the patient is a good candidate for surgery. There are 3 trials that I skimmed through that affected these guidelines. These are the Barry 2D trial, also some subgroup analysis of the syntax trial, and the latest is the Freedom trial. In the European Society of Cardiology for diabetic patients, there was only mention of the 3-vessel coronary artery disease with diabetes mellitus. It was always, cabbage was always class 1, regardless of the syntax score, while PCI is class 2B in patients with low syntax score, and it was harmful in patients with 3-vessel disease and diabetes with intermediate or high syntax score. The strongest evidence that supports cabbage for patients with diabetes is this systemic review of 4 studies that involved also the Freedom trial. It showed that cabbage has a better outcome and are better for the patients than PCI, patients who are diabetic. Another subset also that was mentioned is the patients with chronic kidney disease. To date, the randomized comparisons of coronary revascularization with cabbage or PCI and medical therapy in patients with chronic kidney disease have not been reported. But a recent post-hoc analysis of the syntax trial on patient chronic kidney disease confirmed the principles for allocating patients to PCI or cabbage, as I mentioned before in the previous slides. So if you use, you should treat, according to this post-hoc analysis, patients with chronic kidney disease as the rest of the patients when it comes to revascularization indication. In patients with previous cabbage, in the European Society of Cardiology, it was class 1 to use the internal memory artery as a conduit in patients where this conduit has not been used. Also, it was class 2A that a redo cabbage should be considered in patients without a patent internal memory artery graft to the LAD. Patients who are candidates for previous cabbage, in patients with recurrent angina after cabbage, repeat revascularization is most likely to improve survival in subjects who are at high risk. Subjects who are at high risk are patients with obstruction of the proximal LAD artery and extensive anterior ischemia, also patients with ischemia in other locations, and those with the patent Lima to the LAD artery are unlikely to experience a survival benefit from repeat revascularization. PCI and cabbage among post-cabbage patients result into similar rates of mid and long-term survival after the 2 procedures. This was a finding in a trial that was abbreviated as the AWESOME trial. Last thing is, what are the characteristics that favors cabbage in patients who already undergone cabbage? Patients who have coronary artery disease that is unsuitable for PCI, patients who have a number of disease bypass grafts, the availability of the internal memory artery, chronically occluded coronary arteries, and good distal targets. While factors that favor PCI, limited areas of ischemia that cause symptoms, suitable PCI target, a patent graft to the LAD artery, poor cabbage targets, and comorbid conditions. Another entity or population of patients are the ones who survive the sudden cardiac death or who have a life-threatening arrhythmia. In the American Heart Association guidelines, it was class 1 that cabbage or PCI to improve survival is beneficial in survivors of sudden cardiac death with presumed ischemia-mediated ventricular tachycardia, caused by a significant, that is more than 70% stenosis in a major coronary artery. This was class 1. Emergency CABG is recommended in patients with life-threatening ventricular arrhythmia that is believed to be caused by ischemia in the presence of left main stenosis greater than or equal to 50% and or 3-vessel coronary artery disease. It is harmful to do CABG in a patient with ventricular tachycardia with a scar and no evidence of ischemia. Another scenario also is an emergency CABG after failed PCI. In the American guidelines, class 1, it was emergency CABG is recommended after failed PCI in the presence of ongoing ischemia or threatened occlusion with substantial myocardium at risk. Emergency CABG is recommended after failed PCI for hemodynamic compromise in patients without impairment of the coagulation system and without a previous sternotomy. It was class 2A also that emergency CABG is reasonable after failed PCI for retrieval of a foreign body, most likely a fractured guide wire or stent, in a crucial anatomic location. Emergency CABG can be beneficial after failed PCI for hemodynamic compromise in patients with impairment of the coagulation system and without previous sternotomy. It is class 2B that emergency CABG might be considered after failed PCI for hemodynamic compromise in patients with previous sternotomy. In case of emergency CABG after failed PCI, it is harmful to have emergency CABG done after failed PCI in the absence of ischemia or threatened occlusion. Emergency CABG should not be performed after failed PCI if revascularization is impossible because of target anatomy or a no reflow state. In patients who are going to undergo another cardiac surgery, CABG is indicated as a class 1 in patients who have a significant coronary artery disease. It is class 2A to use the LEMA to bypass significantly narrowed LAD in patients undergoing non-coronary cardiac surgery. CABG of moderately diseased coronary artery that is more than 50% diameter narrowing is reasonable in patients undergoing non-coronary cardiac surgery. In the European Society of Cardiology, the guidelines for this scenario, which is CABG in the association of other cardiac procedure, it was class 1 that CABG is recommended in patients with primary indication for aortic or mitral or surgery, coronary or mitral surgery, and coronary artery diameter stenosis that is more than 70%. It was class 2A to consider CABG in patients with primary indication for aortic or mitral and coronary artery disease that is moderate, between 70 and 50%. Other clinical aspect to consider before deciding which revascularization modality to use is the patient's ability to adhere to dual antiplatelet therapy. Patients with PCI with either bare metal stent or drug-eluting stent should not be PCI with either bare metal or drug-eluting should not be performed if the patient is not likely to be able to tolerate and comply with that for the appropriate duration of treatment based on the type of stent implemented. The appropriate duration of treatment in dual antiplatelet for the bare metal stent is 30 days at least, and for the drug-eluting stent, it's 12 months. If the patient cannot tolerate the entire period, PCI should not be performed for him. Another thing to consider is the completeness of revascularization. The patient with whatever modality the doctor chooses for him should have as close as possible complete revascularization, because the benefit of complete revascularization was independent of the treatment modality. Another entity was the transmyocardial revascularization. It has been TMR has been used on occasion in patients with severe angina that is refractory to guideline-directed medical therapy in whom complete revascularization cannot be achieved with PCI or cabbage. A TMR with cabbage combination does not appear to improve survival compared with cabbage alone. In some select patients, such a combination may be superior to cabbage alone in relieving angina. For hybrid coronary revascularization, and the American Heart Association guidelines for cabbage, class 2A was that the hybrid procedure are reasonable in patients with one or more of the following. Limitation to traditional cabbage, such as heavily calcified proximal aorta or poor target vessels for cabbage. But this target has to be amenable to PCI. The other condition is lack of suitable graft conduit. The last thing is unfavorable LAD artery for PCI. That is because excessive vessel tortuosity or chronic total occlusion. Class 2B, hybrid procedures may be reasonable as an alternative to multi-vessel PCI or cabbage in an attempt to improve overall risk-benefit ratio of the procedures. Factors that influence the choice of revascularization procedure are the extent and complexity of coronary artery disease, and that can be summed into the syntax score, short-term risk and long-term durability of PCI, operative mortality, and we have established that STS is superior to the Euro score, diabetes mellitus, chronic kidney disease presence, completeness of revascularization, the LV function, and if the patient has a previous cabbage, and the ability of the patient to tolerate and comply with dual antiplatelet therapy. The last slide, after this long presentation, is a summary I found in an article that you can find the references of this presentation. I found it to be useful to see this diagram. It gives you an algorithm that simplifies the complex guidelines for revascularization in patients. I'll leave it to you to go through it. I'm not gonna torture you anymore. And that's the end of my presentation. Thank you for listening and your attention. If you have any question, feel free to ask. If I know them, I might answer.
Thank you, Faisal, for this presentation. Luay, do you have a consultant with you today? Yeah, I think Dr. Walid was with us, but I don't see him now. I'm not sure he left. Or maybe he has some net. Okay, so the question that really matters to you guys is when you are faced with a patient, are you going to memorize all this? I mean, it's really dense, right?
Yes.
So how are you going to do, Mishal, Faisal? How are you going to do if you have a patient like this? How are you going to manage all this knowledge? If you're not going to memorize it, are you just going to depend on the cardiology referral or what?
First, in cases with that are complex, the heart team meeting could assist in deciding whether the patient, what mode of revascularization. And
just in case you are the last one to know all these dense information, they may be as good as you are.
I don't know, there are patients population that I know from my reading benefit more with cabbage. Like, for example, patients with intermediate or higher syntax score with LV dysfunction. patients who are with complex disease and diabetes. These patients benefit more with CABG than with the PCR.
So you're going to recite all the guidelines? It's a big practical question, I think. So each one of you should really carry those guidelines in your telephone or whatever device that you have. Make it accessible, because many times you have to go back to it in a hurry. In a few minutes, you should be able to sort your patient. But if in the case of exam, for example, how are you going to do that? All right, my advice to you, at least you should know for sure the type, the class 1 indications, and you should definitely know the class 3 contraindications. Okay.
دكتور فريد.
أيوة تفضل. مين؟
فيصل يا دكتور. I have one question.
Sure.
If you are going to present these guidelines, how would you do it?
Well, your presentation is excellent, and I think it summarized it very nicely. And I already took some pictures from some of the slides just to remind me about the basics. But for each one of the guys with us, the resident, please review this recording from time to time. Make it a habit to look at it. And if your practice is coronary artery bypass, and most of you is going to be in that category, where 90% of your practice is coronary artery bypass, you should really familiarize yourself as much as possible so you can answer most of these questions just out of on top of your head. But for the occasional surgeons or for the difficult cases, it's better to have a reference in your hand. Okay. Again, coming back to your presentation, I think it was excellent. It summarized it very nicely, and you compared different guidelines. Hopefully one day we'll have our own Saudi guidelines, which may be based on some of those studies just as well, or maybe we'll have one international guideline for everybody to follow. Until that time happens, try to familiarize yourself at least with one guideline, stick to one school of those. And I remind you again, I would have highlighted the class 1, definitely the first maybe a few slides, and then at the end the contraindication, because that's where you should be definitely away from doing any harm to your patients. Okay.
شكرا.
Good luck, guys. ما أدري الدكتور وليد قدر يجي ولا ما؟
هو حضر في البداية بس
they had very difficult. Yeah, they have an emergency yesterday and they went on through the night. So I think he probably will have some issues if that's the case. But anyway, I wish you all the good luck. Yeah, السلام عليكم.
السلام عليكم.
Dr. Farid?
أيوة.
So Faisal presented the 3 guidelines. So which one we should follow? We'll stick with
طبعا you're asking me, but I came from one school and I will stick to my school. But it doesn't mean that it's okay. خلينا نحطها زي ما قال الشافعي. My opinion is the most rightful one, but it may be wrong, and the other opinion is definitely wrong, but it may be right. أي والله يعينكم. فيصل على فكرة we just discussed this morning في المجلس على دراستكم اللي بتسووها أنت والدكتور وليد. أرجو أنكم تدونا جواب هذه السنة قبل بداية السنة الجديدة 2021.
أبشر يا دكتور.
يا الله بالتوفيق إن شاء الله.
السلام عليكم.
أهلا وجدنا على فكرة سيرتك يا حسين. ذاك اليوم بتكلم مع الدكتور لؤي على موضوع الجون كلاب.
إن شاء الله في الخير.
ايوه اليوم في الحقيقه كان في المجلس كلام على الجورنال كلوبز. I did not find any candidate, let's say leader, not leader, I should say mentor for the journal club among the guys we talked to today في المجلس. لكن I wish you find somebody around. If not, I don't mind at all being part of that once you are in the issues with هيثم يا لؤي. اوكي تفضل حسين.
بالنسبه للجايد لاينز كلهم طبعا فيهم الخير والبركه، بس الجايد لاينز اللي يعتمدون عليها في اورال اكزام وفي الريتن اكزام عندنا هم الامريكان جايد لاينز.
طيب يعني انت معايا في صفي.
في صفك. دائما في صفك.
Even though if they are old and they are like European updated ones, so stick with the American guidelines.
Well, يعني, as long as you know something is going on and you know what other opinion thinking, that's okay. I think you can find your way, and they will not really hold you very strongly to one opinion or another if you can defend it. But to be on the safe side, يعني, okay, tell them that, يا أخي, I'm carrying this device with me and it guides me, and I think if I plug in the numbers, I can get you an answer. My concern in this case, for example, is a very bad LV dysfunction or the myocardial at risk or the core mobility, and so on and so forth. Yani, show some reason why you're choosing this answer, not that answer. يلا بالتوفيق. ايش برنامجكم دحين؟ اي break again and
yeah, we'll have a break for 10 minutes and then we'll start with the third lecture.
طيب يلا اشوفكم على خير، انا استاذنكم.
So we'll start at 2:45. Abdul Hadi.
Yes.
You can start.
Right. I'm Abdul Hadi Al Anwar. I'm going to be talking about the syntax trial. Just to understand the importance of the syntax trial, we're going to need to know what knowledge was available before and what knowledge the syntax trial provided. So the first question was revascularization versus medical therapy. And to answer that, the randomized veteran affairs cooperative study was the first landmark study to report a survival benefit with CABG over medical therapy for the treatment of left main disease and established the role of CABG as the treatment of choice. This study was followed by the randomized ECSS trial, which demonstrated a significant survival benefit of surgery over medical therapy at 5 years for patients with 3 vessel disease. The second question arose with the development of the stents was stenting versus balloon angioplasty. And the development of coronary stents, the Benston trial demonstrated that in single lesion disease, clinical and angiographic outcomes were better in patients who received a stent than in those who received standard coronary angioplasty, which was standard at the time, of course. At 1 year, no significant differences in mortality, stroke, myocardial infarction, or coronary bypass CABG were found between the stent and balloon angioplasty groups. However, the requirement for the repeat angioplasty procedure was significantly lower in the stent group than in the balloon angioplasty, 10% versus 21%. The stress trial in the United States mirrored these findings. So basically, the stent placement resulted in an improved rate of procedural success, a lower rate of detected restenosis, a similar rate of clinical events after 6 months, and less frequent need for revascularizations of the original coronary lesion. Following that question, of course, came stenting versus coronary artery bypass surgery. And the first or most contemporary multi-center randomized clinical trials comparing PCI to surgery involved the use of coronary stenting and were conducted in the mid to late 1990s. They were the ARTS and the SOS, the ARACI2, and the AWESOME trial. The ARTS trial was the largest trial with 1,200 patients from 69 centers and clearly established that for a patient with multivessel disease, mortality at 1 and 5 years was similar, irrespective of whether the patient underwent stent implantation or surgery. The primary endpoint, which were freedom from major adverse cardiac and cerebral events, or MACE, that is a composite rate of freedom from death, freedom from MI, freedom from CVA, and any repeat revascularizations. Now, this rate was lower at 1 year in the stent group, 73.8% versus 87.8%. This in favors of the CABG. This was attributable to an increased need for repeat revascularizations in the stent group, 21% versus 3.8%. Given a similar survival between stenting and CABG, the major remaining limitation to multivessel stenting was the excess in repeat interventions, mostly due to restenosis in the stent group. Multiple randomized trials have constantly demonstrated that drug-eluting stents, or DES, reduced restenosis compared with the bare metal stent in single lesions with no excess mortality or MI. Various single registries have also reported the efficacy of the drug-eluting stents for multivessel disease. When talking about the left main, following the publications of the Veterans Affairs study, surgery was made the gold standard for left main disease. The major limitation of percutaneous treatment in the bare metal stent was restenosis, occurring in 22% of patients. Because of that, percutaneous treatment of left main disease has remained confined to emergency cases as a salvage procedure and for high surgical risk patients. After the commercialization of the drug-eluting stents with reduction in restenosis rates up to 80% in clinical trials, there has been renewed interest regarding the PCI for left main disease. The first publication on this topic was promising and reported a restenosis rate of 8% in a small population of 16 patients. Larger studies followed that and confirmed the beneficial effect of the drug-eluting stents in this population. However, on the other hand, surgical improvements and advances in coronary surgery, included in the preoperative risk assessment and management, anesthesia, the use of arterial grafts, and improvements in postoperative care. These changes have resulted in a reduced hospital morbidity and mortality despite the increasing age and comorbidities of patients. Furthermore, with the use of the arterial grafts, the occlusion rate of bypass grafts has been reduced. So the major concern about prior trials of CABG versus PCI has been that only a small percentage of patients treated in the real-life clinical setting fulfilled the multiple inclusion and exclusion criteria, precluding a real-world assessment. That finding, plus the advancements in both the PCI and CABG, as well as an increasingly frequent use of PCI for the treatment of left main disease and free vessel disease, formed the rationale for the SYNTAX trial. To overcome the major criticism of the exclusion of patients often seen in daily practice, a nested registry to capture and follow patients not suitable for randomizations is inherent in the SYNTAX trial. The purpose of the study was to assess the optimum revascularization treatment for patients with de novo three vessel disease or left main disease, either isolated or in combination with single, double, or three vessel disease, by randomizing patients to either PCI with the drug-eluting stent, the Taxus stent, or CABG. Patients not deemed adequate by their treating physicians for both treatment modalities will be captured through nested registries, either for CABG or PCI. The CABG registry data will be used to define the population in which stenting continues to be considered unsuitable for the treatment, complex or high-risk subsets. And the PCI registry data will define the patients for whom CABG is considered inappropriate. The study was a prospective, multi-center, multinational, randomized clinical trial with an all-comers design. All consecutive patients with de novo three vessel disease or left main disease, isolated or in association with single, double, or three vessel disease. They are screened by the local heart team. The heart team will first confirm the eligibility of the patients for the SYNTAX study based on a limited number of criteria, which we'll go through. And then we'll agree upon the patient's eligibility for PCI or CABG. Patients deemed fit for both revascularization modalities by the local heart team will be randomized and stratified at each site based on the presence or absence of left main disease and medically treated diabetes. Those patients deemed fit for only one of the treatment modalities will be allocated to one of the nested registries for either PCI or CABG registry. Patients not fit for either treatment option will not be included in the trial. The inclusion criteria used was patients with stable or unstable angina pectoris with ischemia, patients with atypical chest pain, asymptomatic with demonstrated myocardial ischemia. De novo lesions eligible for coronary revascularizations, both PCI and CABG. At least one significant stenosis in all three major epicardial territories, supplying viable myocardium, or significant stenosis in the left main or left main equivalent, with or without stenosis in one of the other vessels. Patients with hypoplastic right coronary artery with absence of a posterior descending artery and presence of a lesion in the left anterior descending artery and left circumflex territories may be included in the trial as a 3-vessel equivalent. Vessel size should be at least 1.5 millimeter in diameter as assessed by a diagnostic angio. Of course, written informed consent and assigned heart team decision formed between the interventional cardiologist and surgeons, and the selected case meets all the inclusion and exclusion criteria. The exclusion criteria were patients younger than 21 years, previous PCIs or CABGs, pregnancy or intention to become pregnant, ongoing acute MI and cardiac enzymes 2 times the upper limit of normal, inability to follow the patient over the period of 1 year after enrollment as assessed by the investigator, planned need for concomitant other cardiac surgery, concomitant valve surgery or resection of the aorta. Those patients were excluded. Patients unable to give informed consent, potential for non-compliance towards the requirement in the study protocol, single or 2-vessel disease without left wing diseases, participation or planned participation in another cardiovascular clinical study before the completion of the 1-year follow-up. So the recruitment occurred from March 2005 all through April 2007. 4,300 patients were assessed for eligibility. In short, 1,800 patients underwent randomizations. 903 were assigned to undergo PCI, and 897 patients underwent CABG. The 2 nested registries, 1,077 patients went into the CABG registry, and 198 went to the PCI registry. At the 1-year follow-up, 98% of this group had data that were analyzed, and 94%. So there was minimal loss of follow-up. So that gives more further strength to the study. The endpoints, the primary clinical endpoint was freedom from MACE, which is major adverse cardiac and cerebral vascular events, through 1 year after allocation. This includes the all-cause death, cerebrovascular event or strokes, documented non-fatal MIs, and revascularization by PCI or bypass surgery. Secondary endpoints included the following: the overall MACE rate at 1 month post-procedure, 6 months, and 3 and 5 years post-allocation. Rates of the individual components of MACE at 1 month, 6 months, 3 and 5 years. Freedom from MACE, quality of life, cost and cost-effective, and the analysis of the characteristics, including comorbidity and coronary vascularizations complexity scoring, referred to as the syntax score of the PCI versus CABG randomized cohort, the PCI registry cohort, and the CABG registry cohort. Results at the 1 year. At 12 months, the incidence of major adverse cardiac or cerebral vascular events was lower in the CABG group, 12.4% versus 17.8% in the PCI group. The rate of repeat revascularization was significantly higher among patients in the PCI group than among those in the CABG, 13.5 versus 5.9%. The rate of stroke was significantly higher with the CABG group, 2.2 versus 0.6%. The all-cause death rate was similar between the 2 groups, 7.6 versus 7.7. The rate of death from cardiac cause was greater with PCI than with CABG, 3.7 versus 2.1%. The rate of death from non-cardiac cause, although non-significant, was higher with the CABG group, 1.4 versus 0.7%. So this showed that the major component responsible for the favorable outcome of the CABG was the rate of revascularization. The stroke is in favor of the PCI, and the rest was similar between the two groups. Now, the outcomes according to the syntax score in the CABG group, the rates were similar with the low syntax score. So 14.7%. This is the rate in the CABG group for the major adverse cardiac or cerebrovascular events. 14.7% in the low syntax group, and 12% in the intermediate syntax, and 10.9% in the high scores. In the PCI group, the high syntax score scored 23.4% complications rates, comparable to the 10.9. This is definitely in favor of the CABG. The low scores was 13.6 compared to the 14.7, not much difference there. And the intermediate score is 16.7 relative to the 12.0. So you can see as the time goes by, the CABG begins to become favorable, and less rates of complications occurs. The conclusion of the one-year follow-up showed that CABG, as compared with PCI, is associated with a lower rate of major adverse cardiac or cerebrovascular events at 1 year among patients with pre-vessel disease or left main coronary artery disease or both, and should therefore remain the standard of care for such patients, especially when we're dealing with high syntax score. 5-year follow-up results. MACE rates were 22.9% in the CABG group, 37.3% in the PCI group. So this is also favors the CABG group. This is the all-cause MACE rate. MI rates 3.8 in the CABG group, 9.7 in the PCI group, also favors the CABG. Repeat revascularization 13.7 versus 25.9% in favor of CABG. The all-cause death 11.4 in the CABG group and 13.9 in the PCI group. Stroke 3.7 and 2.4. So in the all-cause death and stroke, there is no statistical significantly difference between the two groups. Based on the syntax score, 28.6% of patients with CABG had MACE versus 32.1% of the PCI groups. This is the low syntax. Intermediate syntax 25.8 versus 36.0. So that we began to see that the intermediate syntax group now favors the CABG at the 5-year follow-up. The 26.8% is the high syntax score, 26.8% in the CABG group, 44.0% in the PCI group, so that definitely in favors CABG. The low syntax score still shows no statistical difference between the two groups. So the conclusion of the 5-year follow-up is that CABG should remain the standard of care for patients with complex lesions, high or intermediate scores for patients with less complex disease, low scores, or left main coronary disease, PCI is an acceptable alternative in the low scores. 10-year follow-up results. At 10 years, 28% of patients had died after PCI, 24% died after the CABG. Among patients with 3-vessel disease, 28 had died after PCI and 21% after CABG. Among patients with left main coronary artery disease, 27% of patients died after PCI and 28% after CABG. So this 10-year follow-up shows no significant difference in the all-cause death emerged between the PCI with CABG and at 10 years. In patients with 3-vessel disease, CABG provided a significant survival benefit over PCI. No treatment differences were identified in patients with left main coronary artery disease. So the summary of the follow-up, the original trial demonstrated that the primary endpoint of major adverse cardiac and cerebrovascular events was lower in CABG compared with PCI at 1-year follow-up. The 5-year results of Syntax showed that MACE was still significantly higher in PCI compared with CABG. At 10 years, there was no significant difference in all-cause mortality between PCI and CABG. But CABG provided a significant survival benefit in patients with 3-vessel disease, but not those with left main disease. However, this new analysis at the 10 years follow-up has several limitations that should be considered. One of which is that it reported only one of the original endpoints. It only commented on the all-cause death. And that warrant consideration when interpreting these findings. That was the end of the Syntax trial. New trial, the Syntax 2 trial, which is a different study. This uses the so-called state-of-the-art PCI and compared the outcomes of that approach with the outcome of the PCI arm of the original Syntax trial. Patient experienced less MACE rates, 10.6 versus 17.4, compared with the PCI arm of the Syntax 1. The difference was mainly driven by significant reduction in the incidence of MI and revascularizations. Rates of all-cause death and strokes were similar. So this is comparing the new PCIs with the old PCIs. The Syntax 3 trial, which is a totally different design, it was a blinded trial that does not randomize patients, but randomize the doctors or the heart team to make a decision on the best treatment for complex coronary artery disease. This decision was based either on a multi-slice CT angio with physiological assessment using the FFR or on conventional angiography. The trial showed that treatment decision making between CABG and PCI based on coronary angio, coronary CT angio, is in almost perfect agreement with the decision derived from conventional coronary angiography in patients with left main or 3-vessel disease. This supports the potential role of non-invasive imaging with coronary CT angios for treatment decision making and planning. These are my references, and this concludes my topic. Thank you.
Thank you, Dr. Abdelhadi. I have a comment that I'm not convinced still. How come we compare stroke with the surgical and a minimal invasive like BCI? So with the whole stress we go in during surgery, we are comparing this with the BCI. I'm still not convinced with this. I don't know. How come we compare stroke in a surgical patient with the bypass and everything we go through with the BCI?
I'm not following your question, Doctora. I'm not understanding you're in disagreement with the comparison between these two
I mean,
treatments.
regardless the trial, I mean, how come it's not comparable? And I mean, I always say, how come you compare things that are really different? Yani.
They are not different in their goal, which is revascularization. Of course, the effort is different, and sure, the expenses are different, but the goal at the end is revascularization.
Yes, revascularization, but of course we didn't take the patient for surgery. يعني if he can go for BCI, خلاص he can go for BCI. Means there is something that we have to take him for surgery. We are forced to take the patient for surgery.
What's going to make us decide if he can go for PCI or if he can go for surgery?
The anatomy, the clinical situation with the patient, the age, everything.
And that was the reason for this trial, to show that three vessel disease, the left main disease, which is best for the patient, because our goal is to preserve the life of the patient. So which is better in this scenario? This, of course, this is not standardized to all patients. Each patient should be tailored approach. But in generally speaking, we want to compare and see, does PCI completely replace CABG? PCI is definitely less traumatic for the patient. But we saw from the trial that CABG is still superior. PCI failed to achieve non-inferiority at 5 years and at 1 year.
Dr. Ayat?
Dr.
Also, stroke, even though it's is a complication of PCI. When PCI and CABG are both modalities or methods of revascularization.
Yes, but the stress in PCI and everything we are doing in surgery is real different. Yani it's not comparable at all. Yani we cannot compare PCI with surgery. That's what I mean.
So you are saying, Ayat, that it's okay to have stroke after CABG because of the stress of the surgery?
No. I'm saying that you cannot compare it.
Dr. Ayat, there is two issues regarding your question. The first issue, we don't take patient for CABG because it's not suitable for BCI. No. We take patient for CABG because there is certain indication to improve survival of this patient. Even if this patient with 2 vessel disease or 3 vessel disease and they can do BCI, still we will take him for CABG because of the survival benefit. Because CABG showed survival benefit comparing to BCI, and BCI associated with recurrent need for revascularization. Regarding the stroke, it's fair comparison, because at the end we are looking to the patient style or lifestyle after the procedure. If it's high risk procedure, it's better to give this patient BCI. If it's not, and he is suitable for BCI and CABG, we will look to the survival of this patient. Imagine if you take patient and he developed stroke after CABG, his life, even the expectancy of his life or survival, it will not be great because of stroke. I know it's BCI, it's minimal invasive, and sometimes minimal invasive doesn't mean less stroke. If you compare this with the TAVI, TAVI is minimal invasive but associated with more stroke. واضح الفكرة ولا؟
واضح. I'm just saying that BCI is nothing with يعني in comparison with surgery, what we go through during surgery. I don't know. I understand your point, Dr. Hussein.
Exactly, Ayat. So you're right. It's more aggressive CABG. So why they are comparing? So they're comparing because they're saying if you want to go for CABG, this because there's it's more invasive, it must be justified. So the outcome, the long-term outcomes, the patient outcome at the end must be justified. Otherwise, this patient should not go for CABG. That's why they're comparing. They're saying the risk of stroke is higher. They're comparing not only this, they're comparing multiple stuff. So they're putting what is good here, what is bad here, and they're like weighing risk and benefits. In general, this is just the concept of usually comparing the complications of both. That's why, is it justified to go with such aggressive approach is the cabbage? That's why they're comparing. I hope I made it
And
simple.
Dr. Ayat, what's the risk of stroke with cabbage?
You mean
2 to
the
3?
incidence?
Yeah, 2 to 3%. So it's not that high, right?
Okay, it's not that high, but we have the risk. The risk is there with the bypass and everything we are doing there in the OR, and the cut down and everything.
Yeah, but
We are
risk
not.
of stroke, it's 2 to 3%. So it's not high risk.
Okay. Thank you guys for the nice discussion. Thank you.
I have one question.
Mm-hmm.
In the guidelines, they mentioned you need to explain to the patient while consenting him why you are doing the procedure, meaning that which goal you are chasing, either to improve survival or symptoms. How can we consent our patients here, taking in mind this information?
I'm not following. You are asking what to tell the patient and what to report?
Yes. Like if I'm gonna do the procedure for a patient to improve his survival, how would you explain this to a patient here who's Muslim? You will tell him, I'm gonna do this to improve your survival, or you're gonna tell him that I'm gonna do this cabbage just to improve your symptoms, so you don't have a chest pain. I'm not gonna prolong your life. We know that's not correct. It's a chance.
I don't have enough experience to answer, but I would imagine what I would do is just.
Dr. Abdel Hadi, this is just a question for discussion. It's not only for you. You are free and you can participate, but it's for everyone, also from the seniors. How to consent patients regarding our goals.
لو فرضنا انه المريض عنده تريبل فيزل ديزيز، هتقول له انه لو كان ينفع للبي سي اي اتس نوت كومبلكس بي سي اي وينفع للكبج، هتقول له انه لو سويت بي سي اي 3 احتمال كبير انه واحد منهم يسكر من 6 شهور الى سنه، وتحتاج تسوي بي سي اي مره ثانيه، ومو مضمونه انه المره الثانيه يقدرون يفتحونه بالبي سي اي، فممكن انك تحتاج عمليه بعد البي سي اي. بس لو سويت عمليه الفزل الرئيسي، الشريان الرئيسي اللي يغذي القلب، هنحط عليه شيء من جدار الصدر اللي هو الليمه، وهذا في الدراسات عندنا فتره بقائه اطول مقارنه بالاذر موداليتي.
I understand.
I think Faisal, your question is how to explain to the patient that
yes, the concept of survival
will improve your survival, not explaining the procedure, isn't it? صح?
Yes, the concept of survival or symptom relief.
Yeah, I think symptom relief is, I believe it's easy one to do, right? just نقول له ان مثل العمليه هذه راح تحسن من مثلا آلام الصدر، راح تحسن من التعب في النفس اللي يجيك regardless of the presenting symptom. Okay, I think for the survivor it's tricky. I think يعني the way you look at it يعني and I always at the end when I explain the complication I say after explaining that death is a possibility and this will improve. I think أن الأعمار بيد الله. I think if you explain from a point of view that إن يعني الأعمار بيد الله، لكن هذا السبب، والسبب جاك لعندك انه يحس يعني يطول من عمرك حسب بالسبب طبعا. فمكتوب يعني هو انا I've never had a problem with patient having this يعني understanding this concept ان احنا نبذل الاسباب والاعمار بيد الله. انا ما ادري is there a scenario in your mind maybe it will make our discussion easier and a patient had difficulty in يعني understanding the survival.
بس قصدي يا عبد الله، هل قد رحت عند مريض وقلت له الصراحه احنا نسوي لك العمليه اليوم عشان ان الابحاث ورتنا انها تطول عمرك؟ هل قد قلتها زي كذا؟
لا، مو فيصل. الامبروف سرفايفل مو معناته انه يطول عمره نفسه ما راح يتغير، بس الفكره انه ما راح يحتاج انترفنشن او اكيوت ايفنت مع البروسيجر هذه.
يعني ما هو امبروف سرفايفل، امبروف كواليتي اوف لايف. سرفايفل معناه انه يعيش.
لا، كواليتي اوف لايف معناها symptoms وهارت فيلير.
طيب سرفايفل
which is true. سرفايفل انه يعني بالعربي كذا مو يعيش اطول، ما يموت اسرع.
بالضبط زي ما قال.
ما ادري فيصل في allow me. انا سوري
تفضل.
ايوه انا usually when I explained to the patient survival issue قلت لهم انه يعني الدراسات اللي تسوت regarding this topic انه showed انه المجموعه اللي يعني خضعت للعلاج هذا عاشوا فتره اكثر. فهذا اللي اقول يعني الدراسات اللي تسوت اللي مثلا راحوا بيساوي واللي راحوا الكبج عاشوا اكثر. فthis is the way I put it for the
يعني فيصل assuming يعني just roughly كذا assuming انه عائلتهم يموتوا على عمر 70، لو سويت العمليه ما راح يعيش لعمر 80 هو، بس ما راح يموت على عمر 50 او 60. طبعا كل شيء الاعمار بيد الله وعوامل ثانيه تلعب دور، بس اذا اخذتها بس من هالمنظور فانت ما راح تزيد عدد سنوات حياته، بس تمنع انه يجي له مشكله مبكره وتخلي السرفايفل حقه اقل من مقارنه بالناس اللي في نفس عائلته.
ما I don't think this is accurate حسين. لانه overall population everywhere يعني improved survival rate overall بسبب mainly driven by improving بالcardiovascular. يعني مثلا قبل 20 سنة الناس مثلا كانت تموت على 50-60، صارت لا expected age يعني على for example 70 something بسبب الموضوع هذا. ف I don't think this is accurate إنه إذا عائلته مثلا ماتوا كذا هو يموت بالعمر هذا.
لا أقصد إنه يعني we are not adding years to his survival كثر ما حنا. أنا مو عارف شلون كيف أوصل الفكرة يعني إنه
لا if I may
I think from my understanding of the concept of improving survival with LEMA to LED is by reducing the risk of sudden cardiac death either due to arrhythmia or so forth. So simply I can tell the patient by doing such a procedure minimizing the risk of having a sudden cardiac death for certain causes, and that's why your survival is improving. It's the same concept I think of what Hussein is mentioning. It's not prolonging your life, it's preventing what causes your death become earlier, such as VTAC and other causes that are prevented by LEMA to LED or shown by studies there's the decreased risk of sudden cardiac death.
Which mean increase your survival.
Yes.
Exactly. Increasing your survival. Yeah. By preventing what caused your death earlier.
بس انت ما بتقول حق المريض تقول يعني بتطول عمرك، تقول احتماليه الوفاه عندك بتقل لو عملت الكبج.
صحيح صحيح. يعني بقول للمريض
مقارنة بالبي سي اي.
صحيح، بقول للمريض انه احتمالية حدوث المضاعفات لأمراض شرايين القلب اللي بتؤدي للوفاة المفاجئة بتقل في حال خضوعك للإجراء الفلاني.
هو مو بس الوفاة المفاجئة، كل العوامل. يعني لو deterioration of left heart function also يعني improve survival وال quality of life. فكل يعني كيف انك تقول له نسبة المضاعفات هتكون اقل على المدى الطويل.
والله انا for me I never يعني put the patient himself. يعني ما اقول له انت اذا سوينا لك العمليه انك راح تعيش. اقول لا، في الدراسات اللي اجرت للناس اللي عندهم نفس مرضك شافوا انهم عاشوا اكثر. بس هو after the surgery either dead or alive، يعني 50-50. ايوه
شكرا. يعني نفس هذا ايات، هذا نفس الكلام اللي يقوله فيصل، نفس الكلام اللي كان يقوله الدكتور فريد. انت لما تقولي للمريض انه نسبة الستروك 2%، هذا ما تعني شيء للمريض. 2%
انت شايف
معناها
الكومبليكيشنز اللي احنا نعمل لهم كونسنت عليها it's not only stroke.
لا اقصد انه
انا I don't know how do they
لا خليني اقول لك
such a thing. سبحان الله.
لا خليني اقول لك وهقول لك ليش هم يوقعوا. معناته انه في كل 100 مريض 2 هيجيهم ستروك. المريض ما تفرق معاه ال 98 بيشنت اللي ما جاهم. لو جاته ستروك فهذه النسبة 100% بالنسبة له. الشيء اللي يخليهم يوقعون انه لو حسبتي نسبة المضاعفات ونسبة الوفاة ونسبة الكومبليكيشن والستروك والفيلير وكل شيء للمريض نفسه بعد العملية هيطلع لك نسبة معينة. لو ما سوى العملية النسبة أكبر. مو معناته أنه نايم في البيت نسبة الستروك هتكون أكبر عنده، نسبة السادن هارت ديث هتكون أكبر عنده. لو جاكي ليفت مين لنفرض 99، كم نسبة أنه يجي له سادن هارت يموت، يعني يصير له سادن هارت ديث؟ نسبة كبيرة صح؟ مقارنة بمضاعفات العملية nothing.
Yes.
بس
فعشان كذا
على نقطة 2% حقة الستروك، بعض الأحيان أواجه مشكلة لما أكلم المرضى على الستروك، يعاملها كأنها نسبة ثانوية. تقول له 2% يعني 98 ما راح يجيني ستروك. طيب يمكن هو ما أحس بعض الأحيان المرضى ما يفهمون ممكن أنت تكون 1 من 2%. أنت قاعد تخاطر
عشان كذا أنت ما تقول للمرضى نسب. وحتى لو سألك تقول له في كل 100 مريض 2 يجيهم.
ممكن يكون هو 1 من 2.
وهذا شيء ممكن يكون هو منهم، بس هذا شيء مطمئن. يعني لو أنا مريض وقالوا لي من 100 مريض 2، معناته إنه في فرصة كبيرة إنه ما راح يجيني شيء إن شاء الله. بس لو قلت لك إنه 50% هيجيهم، ففرصة المريض إنه يجي له ستروك أو كومبليكيشن هتكون كبيرة.
الصراحة أنا اللي أسويه ما أدري هو صح ولا خطأ. أجي أحطها له في ميزان، أقول ترى ممكن أنت عندك النسبة هذه إنه يجيك جلطة، بس أيضا في النسبة هذه تموت. إذا ما عندك إنك تعيش وفي احتمال تخاطر فيه إنه يجيك جلطة، فأنت راح تخاطر بس من أجل إنك تعيش، فرصة إنك تعيش أطول. أدري هل هذه صح إن زي كده تتكلم المرضى فيها ولا
شوف طبعا النسب موجودة. يعني مرة مريض قال لي جملة حلوة لما قلت له عن النسب والستروك، فقال لي إنه تتوقع كم نسبة الوفاة لما أجي لو أجي من البيت إلى المستشفى؟ تتوقع أن 100% هوصل سالم؟ قلت له لا، في نسبة إنك ما توصل سالم، بس ما أعرف النسبة بالضبط. فقال لي معناته إنه كل شيء بيد الله، والنسب موجودة في كل شيء، ما في شيء 100%.
ما كلها.
طيب, I have another question. We saw that in syntax in 10 years it showed no difference in patient with the left main, not with the triple vessel disease. However, 5 years showed better outcome favoring cabbage. So if you have a patient like 70 here in our population, and if you depend only on this study, for example, so his life expectancy is 75 around. So would you go for CABG or BCI? I'm not sure if I made my question clear, but
it's clear for me. If I'm the one answer this question, if Faisal, I will weigh the risk and benefit. If he is excellent 70، يعني في 70 وعنده مزرعة ويروح ويجي ويروح المسجد ويسوي كل شيء في الحياة، I may take him for surgery.
Okay.
لو كان لا bad 70، عنده osteoporosis، عنده renal disease، عنده frail patient، يمشي على عصا، BCI better for him. مو عشان انه لانه عمره 70 75 الافرج في السعوديه يعني من 70 الى 75، صح ولا انا غلطان؟ فانت you are not adding survival benefit مع الكبج. وحتى لو اخذته عمليه، في ناس يقول لك يعني اتس ما ادري هتاخذ له مامري ولا ما راح تحط له مامري، لانه ما في survival benefit.
لا هو at 5 years there is but at 10 years there is no difference.
لا اقصد ان جنرال في المريض هذا اللي عمره 70، لانه عاده اللي اعمارهم 70 الريكفري فروم كارديوبولمونري باي باس يعني الهارت الاجكشن فراكشن it should not be normal usually. وعندهم other comorbidity، عندهم osteoporosis، عندهم risk stroke اكثر، عندهم risk of external wound infection اكثر. فاذا اخذت هذا يعني if you خليت كل مريض على حده هتكون ايزي. هيجي لك مرضى عنده رينال ديزيز اوستيوبوروسيس، فهذا هاي ريسك انه يجي نون كنترول دايابيتس، فهيكون هاي ريسك انه يجينا ستيرنال ووند انفكشن، فبي سي اي ممكن تكون افضل له. يعني في بعض الحالات ناس اعمارهم في الخمسينات ولما نناقشهم في المورنينج ميتنج يكون المريض موربيد اوبيس وعنده ليفت فين، فالاصوات كذا في المورنينج ميتنج كلهم يروحوا او اغلبهم الى بي سي اي.
فير
عشان الكومبليكيشن. طبعا برضو هم يعني يروحوا بي سي اي اكثر لو كان الليجن اوستيال، لو كان في الترانك حق الليفت مين بعيد عن اللي هو البايفوركيشن حق الاي دي والسيرك، يعني ايزي بي سي اي with low syntax score.
يعني you use this information according to, for example, patient age, and you would differentiate between this 5 and 10 years, huh? Well, you just take the 10 years. Okay. Good. Any other thought?
عشان انت فصلت بالموضوع، قلت ان اذا كان او بس الحين the question I think فيصل suggesting ما تصلح فيصل انه at 5 years in this patient the cabbage will be better with the syntax score، صح ولا لا؟
Yeah, according to this study, 5 years mortality was less in cabbage patient, but at 10 years they equalize or shows no difference between cabbage and BCI.
Anna, for me, I think it's.
Give me two, please.
Cabbage, yeah, totally sure. I think if cabbage would would improve his survival. If you're saying his life expectancy, it showed that it improved survival or more survival at 5 years, and you're expecting him to live those 5 years. So with cabbage, he's more likely to live up to those 5 years.
هذا معناها good 70 good 70.
ليه أقصد يعني هذا الكويستشن اللي يعني فهمته من فيصل which is good 70.
Yeah, but you have other tools. You have the functional status of the patient. You can calculate his risk score, STS or your score, and then maybe you can decide from the
Yeah,
And
low
and the
risk
the frailty and
frailty index as well. Yeah.
so it's difficult to say it as general rule. More than 70 will send them for BCI, or less than 70 will take them for cabbage. You have to take every case by case. بعد دكتور فريد موجود ولا؟
أيوة معاكم. So first of all, my advice to you is not to discuss survival or survivor benefits with your patients in general. And it's better to say, to start your conversation with your patient or their legal guardian by asking what they understand so far about the pathology of their disease or the disease, and what's their expectation, and start the discussion in that direction by setting up the expectation. Now you go in, Faisal, you go in with already determined what's the best for the patient. Let's say you want to do a cabbage, so you tell the patient that I'm going to go in for a cabbage, but I may fail, I may not be able to do it. And if that's the case, these are the alternatives that I have. I try to make it as simple and as truthful as possible. The question that Ayat had said, her concern that you cannot compare, I think Ayat, you have a mental block. You should always be able to compare anything with anything. You can, for example, you have a summer vacation. You can decide, should I stay by the pool, or should I go and operate or write a book or something, or read a book? Totally different issues, but you will find something meaningful in between. And the meaningful things that we are looking at, like Faisal answered you, is that we're looking at survival, we're looking at elevation of symptoms. And by the way, Faisal, when you look at the coronaries, with those two considerations, we are actually looking at three potentials. Either we can save an infarcted area from infarction, not infarcted, but ischemic area from infarction, or we can reduce the infarct size, or last thing is that we can prevent future events, be it another MI, or be it that kind of arrhythmias or whatever issues that can affect the patient's life. Okay, that's my 2 cents in the issue. Thank you.
And regarding revascularization in 70 years old, Dr. Farid, left main with 70 years old.
I always attempt to use the left main. If I have a concern about the, lima, if I have a concern about the issue of complications related to lima, then I will go to deliberately from the beginning, all veins. I had the emergency done in somebody who's 90 years old. And it's an emergency. I know I could do the lima, but it's gonna be time consuming and maybe no further benefit. So age of 70 is not necessarily cut off. Sometimes you go and shake your hand with Dr. Luai, for example, and you feel that he looks like 50 years old, or 70 or 80. And sometimes you shake your hand with 80 years old and you know he's younger than you are.
Do you consider
Thank you.
alternative to surgery in these patients sometime?
Always. And that's the main question for comparison in this Syntax group, is that they're trying to find anything less invasive, less harmful than the surgery. Let's say, Ayat, for example, this particular patient, 70 years old, the studies have shown that PCI have a mortality rate, let's say, of 5%, success rate of 90%. Then you look at the cabbage. They say the cabbage have a mortality rate of 20%, and the survival rate is let's say, comparable. Then it's very obvious. The answer, you'd go with the least invasive. The same for testing, the same for surgery, the same for everything. As long as you're reaching your goal, which is survival benefits alleviation of symptoms? Is there a better way? Is there a simpler way? Is there a less invasive way? Thank you.
Sure.
I think robotic lima to cabbage in such scenario is a game changer.
Everything in life is possible and potential. I like to look at the end results. At one time, they said beating heart surgery, minimal invasive, and we discovered that the lima in those patients is not as good as the surgical with cardiac arrest, arresting the heart. The numbers are not good, but the numbers are good enough for somebody whose life expectancy is 5. Okay, but if I'm looking for somebody to live another 30, 40 years, maybe it's a different issue. But I'm not saying that you cannot do it, and it may not be. Show me the evidence, show me the numbers, and I'll go with you.
Dr. Farid, I have one.
Do you have a consultant with us today? Do we have a consultant today with us? Is he back or with the group?
No.
Okay, so معناته اقدر اخذ راحتي وافسخ العمامه على قولك. تفضل.
Dr. Farid, I have one question. If you have one patient with the left main and two physical disease, not diabetic, and he's low syntax score actually, what's the best option for him?
Well, you may be contradicting yourself here. Just mentioning low syntax score means that those vessels are not diseased significantly. Again, I would ask you to stratify and give the exact numbers for all these things. But regardless, if the patient by the syntax group, let's say, score is evident that he will benefit from the surgery, he will benefit from intervention, be it cabbage or be it PCI. I would personally prefer to go, and they are equal according to the literature. I would still prefer personally to go for surgery.
Okay.
But I mean, please, we don't have many answers. We don't have many answers to many questions. Let's say somebody comes up with a really good, very good study showing that if you do surgery, they have worse scenario. The stroke rate, which is 3%, 4%, is very significant in their life, and the outcome is not really great. And the expectancy in that group of patients in that particular location or country is this much. So yeah, be open. I mean, keep your mind open. You may be able to, and you ask the patients, what's your preference? He may not like it to have his sternum cracked.
Dr. Farid.
Go ahead, please.
Once in a heart team meeting, there was a discussion for a patient case who was more suitable for cabbage, but
okay,
PCI, even though it was harmful for him. So
no, wait a minute. Wait. Did you say you already have decided that his PCI is harmful?
Yeah, PCI was inferior. Sorry for that patient.
Okay, inferior is a different issue. But if you say it's harmful, then the answer is very obvious.
But I remember it's harmful. The question is not what is the decision. It's an ethical issue. The patient was, we were expecting that he will not be compliant on his dual antiplatelet. So cabbage was better for him.
So you have a good reason. Yeah, you see, that will be definitely the answer.
But the patient,
now you have
but the patient, the story is still not complete. The patient chose to go for PCI. So in the heart team meeting, some of the consultants were saying, we will only offer him cabbage. We will never offer him an inferior option. If he wants that inferior option, he should go for somewhere else. Is that a good stance to have?
Okay, yes. it's not a bad practice, but I think please you look at all the options. Meaning, sometimes you'll see a patient that you believe that the best option is A, okay, but the patient chooses B. All right. If your colleague is willing to operate to give him that chance of B, that's fine. So he's off. You are off the hook, and he have done what you choose. But you are the only one in town. You are the only surgeon in town. Okay, and that's the patient's preference is this much. You know it's inferior. You know it's maybe 50% less than what you wanted with surgery. You should go with the patient's wishes. It's not unethical, no. But of course, I would expect you to have sat down with the patient, consented him, and tell him that this is a better option. You are choosing a less option. I will do it because I'm the only one here who can do it for you, but I'm not really convinced that you should go this way.
So
And
it's a
Faisal, by guideline, if patient cannot take anticoag or he is not compliant, it's contraindicated to give him BCI.
That's the question: is am I allowed to say no, go somewhere else? Or but Dr. Farid said if I am the only one, it's okay to give him this option.
It's okay to give him this option, but knowing the fact that it's no harm, you have an option. Let's say you have a guideline saying it's a class 1 indication to go for CABG, and it's class 2B to go for PCI. It didn't reach the class 3. If it's class 3, I would definitely not do it.
Okay, I understand now.
Yeah, if it's high syntax score and they will not be able to do the BCI. Nobody can force them to do BCI for the patient, even if the patient insists to get BCI.
Okay, I understand.
Hussein?
Sam.
Do you usually calculate the syntax score at your center while during the meeting, or it's just a matter of experience?
The cardiology they do.
They eyeball it.
Yes, but because of their experience, they eyeball it and they get the syntax score. But as a surgeon, we don't calculate it usually.
I know, because in our meetings we don't usually calculate, but just by the cardiologist will say this is a difficult PCI from his experience only. So I'm not sure other centers they are doing the same or not.
We are doing the same.
I think you should train yourself to calculate it for each patient you attend to. Okay, it's good for you, and even in the future, you may be liable if you don't. Our practice does not necessarily mean it's the only practice. Okay, and many times you may be brainwashed not to do it because it's easier not to work on it. That you spend another half an hour just working on this, trying to get the patient calculation. So please, the best practice in hospitals and quality measure is that you actually work on this issue.
Yes.
Yeah. I have a question for Abdul Hadi regarding the Syntax 2 trial. They mentioned state of the art. So did they use a different stent, or why it's different from the Syntax?
It was a different stent, a more modern one, but I do not remember its name. But they did not use the same Tax's stent.
لو أي الستوري كلها كذا يعني كل study تطلع showing cabbage better than BCI, they will change the design and they will change the stent and they will do study again. But they are comparing with the standard cabbage. They are not comparing with the new style of cabbage, like using the radial artery or bilateral mammary.
Or using very good cardioplegia also.
Yes.
Okay. So any other comment from the group?
Just one comment. I think while reviewing this cabbage trials or PCI versus cabbage, be aware that there is different definition of pre-procedural MI, and it make sometimes big difference. Some definition will favor PCI, some definition will favor cabbage. So try to look which definition they used for the especially pre-procedural MI, which is like post-cabbage. You expect it to have some high level of trop and CKMB. But to define when to consider it as significant or not, there is different definition. So this is something we should look at it during analyzing those studies.
Dr. Farid, when you said good cardioplegia, you are referring to what? To blood cardioplegia or more recurrent cardioplegia, or?
I would personally use the custodial, but there is some evidence that if you use some sort of blood cardioplegia in very bad patients, it may be better. Ischemic myocardium, infarcted myocardium. So maybe the del nido might be a better option rather than custodial in cases of cabbage.
Mm-hmm.
By the way, somebody was asking the difference between del nido and the blood cardioplegia. Can you answer them? Can you answer them, Hussein?
Yeah, different. The main difference, the percentage of blood for in del nido will be 1 to 4, 1 blood and 4 del nido. In blood cardioplegia, it's reverse. You get four blood for 1 cardioplegia, which is made of high potassium. And the duration, it's different. For del nido, they give you 90 minutes protection. For blood cardioplegia, give you from 20 to 30. And potassium concentration in blood cardioplegia around 20 to 25, depend on the preparation. Because when we prepare it in university hospital, it's usually, or it's 20% potassium. We add 80 milliequivalent of potassium in 1 liter. I hope this answered the question.
Thank you, Hussein. في واحد ثاني. طيب.
Okay, thank you very much for joining us today. We'll see you next week. Just a reminder for next week presenters, please make sure to have someone, a consultant, to be with you. If you did not arrange, please contact me so we can sort it out. Thank you.